Hi everyone, welcome to POC Nurse. I'm Gozi. In this video, we're going to talk about chest tube assessment and management for the respiratory section of the Ccrn exam. I was supposed to include this video in the pneumothorax/hemothorax video I made last, but it skipped my mind. I apologize. So let's start by talking about why do we need a chest tube in the first place. So usually a chest tube is placed if something needs to be drained out of the pleural cavity. That something could be air or it could be fluid. Air, as in the case of pneumothorax. When we talk about fluid, it could be blood, as in the case of a hemothorax. It could be pus, like in empyema. It could be lymphatic fluid, like in a chylothorax. It could be excess pleural fluid, like a pleural effusion. There may be other reasons, but these are the reasons that come to my mind right away. Why do we need to drain the air or the fluid out of the pleural space? Well, if the fluid or the air is left to accumulate in the pleural space, it can squeeze or squish the affected lung. It could be the right lung, it could be the left lung. If it squeezes and squishes that lung, first of all, there will be no air going into that lung. So oxygenation, gas exchange, ventilation will be affected. Now, if that lung gets so squeezed that it can't be squeezed anymore, but the other organs in the chest compartment, in the mediastinum, start getting squeezed, we could have like circulatory collapse. The person could go into cardiac arrest because the affected lung will get squeezed, the heart will get squeezed, the other lung will get squeezed, the vessels leading to the heart, like the inferior vena cava, will get squeezed. Even the aorta could get squeezed. So you see, that's not a good picture. So whatever is in that pleural cavity needs to be removed before it causes damage like this. So be it fluid, be it air, a chest tube can help evacuate that air or fluid so that the affected lung can re-expand, can have room to re-expand. So a chest tube has different parts to it. It has about 3 to 4 main parts. It has a collection chamber. So if you're draining something like fluid out of the pleural cavity, that's where the collection chamber comes into play. So the blood will drain here. If you're draining out pleural effusions, that's where it will drain into. Pus will drain in there as well. If you're draining air out of the pleural cavity, you don't really need the collection chamber. However, you need the water seal chamber because the air will go into the water, bubble into the water, and out. If you have suction, the suction will suction the air out. If the chest tube, if the pleural vac, the box that's connected to the chest tube, if it's not connected to suction, if it's to water seal, you need to remove the suction tubing so that that air that's getting drained out of the pleural cavity can go into the water seal chamber. The water seal chamber has water, so that air is going to bubble into the water that's in the water seal chamber, and then out of it and out of the pleural vac through the vent if you take off the suction tubing, or it gets suctioned out with the suction tubing if the box is connected to suction. The next part is the suction chamber. I just talked about suction a few minutes ago. So the suction chamber is where you would connect your wall suction. However, the wall suction does not control the suction that's happening within the box. So depending on the kind of box you have, if you have like a wet drainage box, like a wet seal or dry seal drainage box, that'll if you have a dry seal drainage box, there will be a pressure gauge on it. Whatever you set the pressure to on the pressure gauge is the amount of suction pressure that will be happening in the box. If you have like a wet seal drainage box, the amount of water that you have in the suction chamber is what will determine the amount of suction that's happening in the box. I hope that makes sense. So we talked about 3 parts to the chest drainage box. We talked about the collection chamber, we talked about the water seal chamber, and we talked about the suction chamber. You could also have an air monitor leak on your drainage box that will tell you if there is an air leak and how much of an air leak that you have. Moving on. After a patient gets a chest tube placed, it's important to monitor the patient pretty frequently in the first couple of hours, or depending on the policy at your place of work. However, we are talking about preparing for an exam here. We're talking about preparing for the Ccrn exam. So you need to know for your exam that, oh, this patient just got a fresh chest tube placed. You need to monitor the patient more frequently. Now let's talk about nursing assessment of the chest tube. So when a patient has a chest tube, we want to monitor the patient's respiratory status closely, as well as the patient's vital signs. After placement of the chest tube, the patient's respiratory status should get better. How do we assess the patient's respiratory status? Well, you want to look at the patient's work of breathing. You want to look at respiratory rate. You also want to listen to the patient's lung sounds. Vital signs are important. You want to check the patient's temperature. You want to check the patient's blood pressure, because all of these could be affected when the chest tube is placed, depending on the reason why the chest tube is placed. Other things we want to do is monitor the patient for pain. So procedure in the chest area like that can be painful. While it can be painful, it can prevent the patient from taking deep breaths. We don't want that. So we want to medicate the patient for pain if they're in pain, so that they can be comfortable and breathe comfortably as well. We want to monitor or assess the dressing site, the insertion site. We want to make sure that it is clean and dry. If there's any drainage, we want to take note of the drainage. You also want to monitor that insertion site for signs and symptoms of infection, such as redness, warmth, etc. It's important to assess the tubing itself. So we put in this chest tube to drain something out of the chest. So we want to facilitate proper drainage out of the patient's chest and into the chest tube. To do that, first off, we have to put the chest drainage system, the box, the Pleurovac, below the patient's chest. So usually it goes on the floor or attached to the bed below the patient's chest. Secondly, there should be no dependent loops. When we have dependent loops, the fluid could sit in those dependent loops and actually prevent the chest drain from draining properly. We want to look at the Pleurovac, the box itself. You want to make sure that there is tidling for one. Tidling happens when the fluid in the water seal, there's usually a ball in there in the water seal chamber. You want to make sure that the fluid is going up and down gently. So you see that ball in the water seal chamber going up and down. Tidling happens as the patient breathes. So when the patient takes a deep breath, the ball goes up. When the patient breathes out, the ball goes down. And this is normal. When you don't see tidling, there could be a kink, a clot, or some kind of occlusion in the tubing system, or the patient's pneumothorax or hemothorax or whatever it is that we're draining out of the patient's chest is completely drained out. The lung is completely re-expanded and the patient is healed. Next thing we want to look for are air bubbles. If there are air bubbles in the water seal chamber, it may indicate an air leak, so that air is leaking out of the tube from somewhere. It could be on the tubing that you can see, that's external to the patient, that's exposed to the atmosphere, or it could be the part of the tubing that's inside the patient that you cannot visualize with your eyes. So air leaks could be continuous or they could be intermittent. They could be intermittent as the patient breathes in and breathes out. When the patient breathes out, there could be air bubbles in the chamber. But when it doesn't matter if the patient is breathing out, is breathing in or breathing out, you just see bubbles in the water seal chamber. That is a continuous air leak. Anytime you see an air leak, you want to let the provider know. When you see that tidling is not occurring, you also need to let the provider know, especially if you've investigated the tubing. You don't see a source of air leak, you don't see any source of where, you don't find any explanation why there is no tidling. If the tubing is kinked inside of the patient, there will be no titling. And if it's a new tube that was just placed, that is very concerning because it should be titling. It was just placed just now. And if it's not titling, it means there is a kink somewhere. If you can't see the kink, that kink might be inside the patient. And if you put that tube in for a reason, just now, let's say for removal of air or fluid, and the tube is kinked inside the patient, that air fluid is not getting removed. It could be accumulating inside the patient. It could lead to a tension pneumothorax. And in a tension pneumothorax, we know that there is mediastinal shift. There is nowhere for this air to go. It's just building and building inside the chest, and it could lead to cardiac arrest and death in the patient. So it's important to note that if this freshly placed tube is not showing titling, it might be kinked inside the patient or outside of the patient. The provider needs to be made aware. They can do a chest x-ray to visualize the tube inside of the patient to make sure that it's kinked or not kinked, to make sure that the patient is okay. Also, you want to make sure of how suction is happening in your chest drainage box. So if the order is for the patient's box to be connected to suction, you want to make sure that it's connected to suction, and you want to make sure that the suction is at the right pressure that was ordered. So if you have a dry seal drainage box, you have a pressure gauge on the box. You want to make sure that the pressure gauge is turned to the appropriate number that's ordered. Sometimes the wall suction will also be ordered. You want to make sure that the wall suction is appropriate as ordered. If you have a wet seal drainage box, you want to make sure you have the right amount of water in the suction chamber. Also, if the order is to put the chest tube to water seal, meaning no suction should be attached to the box, turn off suction. When you turn the suction off, you need to actually disconnect the tubing from the box, because if the chest tube system is still draining air out, that air needs to go somewhere. It needs to leave the box. If the suction is on, the suction will suction the air out. If you turn off the suction, you need to disconnect the suction tubing from the box so that the air can get vented out. Let's talk about clamping the chest tube. So clamping the chest tube is only done under certain circumstances. You clamp the chest tube as a nurse. You clamp the chest tube when you're changing the chest tube, and you don't want to leave it clamped for too long. So you want to quickly clamp it, change the chest drainage box, and unclamp it. If the chest tube itself is clamped for too long, remember we're trying to drain something out of the chest that is causing problems, that is causing lung collapse. If the chest tube is clamped for too long, whatever we're trying to remove will continue to accumulate in the patient's pleural space, and it could lead to a collapse of the lung, mediastinal shift, and cardiopulmonary arrest cardiac arrest when the heart gets compressed, inferior vena cava gets pressed, the aorta gets pressed, and nothing is able to move appropriately into the heart, out of the heart. Oxygenation gets more difficult. The patient might die. So we don't want to clamp the tubing at all. Also, we don't want to milk the chest tube. We don't want to strip for any reason, because clamping, stripping a kinked tube, a clotted tube, an occluded tube for any reason can lead to a tension pneumothorax in the patient's chest, or accumulation of the fluid that you're trying to drain out in the first place in the patient's chest. Let's talk about some problems or complications that could be encountered with a chest tube. I think this is important to know for the Ccrn exam because the chest tube management and assessment itself is a topic that's bolded in the book. So it's something that we need to know for the exam. So, and they are usually looking for complications, and do you know what to do when a complication occurs? So let's talk about it. So the first complication we're going to talk about is respiratory distress. So you have this patient was placed on a chest tube, patient is supposed to be getting better. Now the patient looks like they are in respiratory distress. So you want to go to your patient, you want to assess why they're in respiratory distress. A set of vital signs. look at your O2 sat, look at your heart rate, look at your blood pressure, look at your patient. What are the signs of respiratory distress you see? Do they have increased work of breathing? Are they tachypnic? Are they short of breath? Do they look anxious? Listen to the patient's chest. Do you hear lung sounds in the affected lung? Do you hear lung sounds in the unaffected lung? In the affected lung, how has the lung sounds changed over time? Was it getting better? Now that the patient looks like they're in respiratory distress, is there any breath sound there at all? Is there absent breath sound, or is there diminished breath sounds? Look at your chest drainage system. Do you see any kinks? If you see any kinks, straighten it out. Are there clots in the chest tube system? Do you see dependent loops in your chest tube system? You want to fix anything that you can fix as quickly as possible. If you need to provide oxygen to your patient, do that as quickly as possible. Look at your patient's chest. Do you see any tracheal shift? You want to get emergency assistance as quickly as possible if you feel that the situation is emergent. The patient might need a new chest tube placed. The patient might need surgery. So your respiratory assessment of your patient that's in respiratory distress is important. You may need to get help quickly. So that's it with respiratory distress as a complication or problem with the patient that has a chest tube. The next complication we're going to talk about is an air leak. So we talked about air leaks earlier. They could be intermittent or they could be continuous. You look to see if a patient has an air leak, you have to look at your water seal chamber. If you have an air leak monitor, it'll also tell you, you see bubbles in there as well. And the air leak monitor can tell you how severe the air leak is. The air leak monitor usually goes from the number 1 to the number 5, from right to left. So number 1 means you have a small air leak, and number 5 means you have a big air leak, and then anywhere in between will tell you like how much of an air leak that you have. The thing with the air leak is that you need to notify the provider that there is an air leak. The patient will also get that air leak placed, get the chest tube placed, and have an air leak in it right away. You just need to notify the provider that there is an air leak, and you need to monitor your patient's clinical status to see how this air leak is affecting them, if it's affecting them at all. Next complication we're going to talk about is the chest tube being dislodged from the patient. So if the chest tube gets dislodged from the patient, that's an emergency. If you have gloves on, cover the wound on the patient's chest with your hand and call for help. Ask someone to bring you a dressing, gauze, and tape. So you want to put an occlusive dressing on the wound, and you want to tape it on 3 sides only. Why do we tape it on 3 sides only? You want the patient to be able to take a breath in, but when the patient takes a breath out, you want that air to escape through the open 4th edge of your dressing that you did not tape. If you tape all 4 corners of the dressing, when the patient takes a breath, air will go in. Remember, this patient has a pneumothorax, or may have a pneumothorax in their pleural cavity. So the patient takes a breath in, air goes into the lungs, air gets trapped in the pleural cavity because this patient has a pneumothorax. When the patient breathes out, that air in the pleural cavity stays right there, and it could build up and cause a tension pneumothorax in the patient, which is why when the chest tube gets dislodged from a patient, cover it with your hand. If you don't have a dressing available, call for help, ask someone to bring a dressing to you. Put that dressing, it should be an occlusive dressing because you don't want air freely going in and out of the patient. Put the occlusive dressing over the wound, tape it on 3 sides only, and leave the 4th side open. Then you want to notify the provider so they can take it from there. The next complication we're going to talk about is accidental disconnection of the tubing from the drainage box, or if you have cracks in your drainage box. So if the tubing gets accidentally dislodged from your drainage box, You could put the end of the tubing, the part that's not connected to the patient, you could put it in a small bottle of sterile water to create a water seal while someone goes and grabs you a new box, and then you connect the patient back to like the Pleurovac box. Once you do this, you want to notify the provider. Now, what if you don't have a Pleurovac box? So this is why, just in case you get asked on the exam, what kind of emergency supplies should you have in the room? If you have a patient that has a chest tube, you want to have supplies for dressing. You want to have an extra Pleurovac box. You want to have, the small bottle of sterile water. So if you don't have the bottle of sterile water, you don't have the drainage box with you, and the patient has come undone, the tubing has come undone from the box, you could clamp the tubing close to the patient and quickly get a new box and unclamp the tubing and connect the tubing to the new drainage box. You don't want to clamp the tubing for any reason as much as possible. And then once you've done this intervention, once you've changed the drainage box, you want to notify the provider. So remember, we're studying all of this for the Ccrn exam. So if you get questions like this about complications with your chest tube, once you do your intervention, you need to notify the provider, because the patient might need a follow-up chest x-ray, they might need a follow-up evaluation from the provider. Always notify the provider once you do your intervention after a complication. The next complication we may have is bleeding. So the patient may start bleeding at the site of the insertion. If they bleed at the site of the insertion, you want to put pressure on the bleeding. You want to put more dressing, reinforce the dressing, and let the provider know. Also, you could get bleeding into your Pleurovac, into the drainage box. If you feel like the patient is bleeding into the drainage box, there's bright red blood coming into the box, and you have 200 ml over an hour for at least 2 hours, you want to notify the provider. The patient might be bleeding inside and the patient might require surgery. Another complication to look out for is subcutaneous emphysema, crepitus. So crepitus may be a sign that there is an air leak in this patient's chest, and that the air leak has gotten so big that it's occupied all the space it's in, and there's nowhere else for it to go except through the patient's skin. If a patient has subcutaneous emphysema and you palpate the area where that subcutaneous emphysema is, it could be around the dressing, you're going to feel like the pop of Rice Krispies. It's going to be like popping under your fingers. You have to let the provider know that this patient has subcutaneous emphysema, because it might represent an air leak inside of the patient. Subcutaneous emphysema could also be a sign that this patient is developing tension pneumothorax. So it's important to notify the physician when you notice a new subcutaneous emphysema, and then you have to monitor it to see if it's extending or if it's getting worse. Another complication of the chest tube is when the drainage out of the chest tube stops, especially if the chest tube was just placed. So if the patient comes out with a freshly placed chest tube, or the chest tube was placed at bedside, because there's fluid to be drained out, and maybe it was draining fluid out when it was first placed, and then suddenly it's not draining anymore. Maybe on x-ray there is like an estimate of maybe the patient has 500 ml of whatever kind of fluid there, and you look at the box, you only have 100, and this thing is not draining. That's a complication. Why? Because the tubing might be kinked somewhere, it might be blocked somewhere, and if it's not draining, that means whatever it's supposed to be draining is accumulating inside the patient's chest. So you want to investigate and see why the drainage stopped. You want to look for kinks, straighten the kinks out. You want to reposition the patient. You want to make sure that the actual box is below the patient's chest to facilitate draining. You also want to make sure that there are no dependent loops, And if you do all of this and there's still no drainage, you want to make sure you notify the provider. Even if you get drainage, notify the provider what happened, what you did, because guess what? Your intervention might only work temporarily, so that when the drainage stops, just call the provider. Okay, look, even after everything, it drained for a little bit, like I told you, now it's not draining anymore. Can you come and evaluate? All right, these are things we need to know for the Ccrn exam. The last complication we're going to talk about is if the drainage unit tips over. By drainage unit, I mean the drainage box, your pleurovac. If your pleurovac tips over, now all the fluid has gone all over the place. It's happened to me once. You don't know where anything is. You don't know how much fluid has drained out over whatever time. Just change the drainage box. Change the drainage box. Remember, you need to clamp. You can clamp the tubing to change the box quickly, and then unclamp the tubing. And what I did to make sure I didn't tip over again, I secured it closer to the bed. I kicked out, that stand that's under the box, kicked it out, make sure that it was, stable on the floor. And yeah, that is what I did. So if your drainage box tips over, no fear, get a new drainage box, switch it out. That will do it for this section of the Ccrn exam. This was chest tube assessment and management. This is a topic that you could get on your Ccrn exam. It is bolded in the book or starred in the book. I hope you found this video helpful, and I will see you in the next one. Thank you so much. Please remember to like, share, and subscribe. Bye bye now.